Sternal and rib fractures. Sternal fractures are most common in motor vehicle crashes with a direct blow to the sternum via the steering wheel and are most common in women, patients over age 50 and those using shoulder restraints. Rib fractures are the most common type of chest trauma occurring in more than 60% of patients admitted with blunt chest injury. Most rib fractures are benign and are treated conservatively. Fractures of the first three ribs are rare but can result in high mortality rate because they are associated with the laceration of the subclavian artery or vein. The fifth through ninth ribs are the most common sites of fractures. Fractures of the lower ribs are associated with injury to the spleen, liver, which may lacerated by fragmented section of the rib. Clinical manifestations. The patient with sternal fracture has anterior chest pain, overlying tenderness, ecchymosis, crepitus, swelling, and the potential of the chest wall deformity. For the patient with rib fractures, clinical manifestations are severe pain, point tenderness, and muscle spasm over the area of the fracture, which is aggravated by coughing, deep breathing, and movement. The area around the fracture may be bruised. To reduce the pain, the patient splints the chest by breathing in a shallow manner and avoids sighs, deep breaths, coughing, and movement. This reluctance to move or breathe deeply results in diminished ventilation, collapse of unaerated alveoli, atelectasis, pneumonitis, and hypoxemia. Respiratory insufficiency and failure can be the outcomes of such a cycle. Assessment and diagnostic findings. The patient with a sternal fracture must be closely evaluated for underlying cardiac injuries. A crackling, grating sound in the thorax, subcutaneous crepitus, may be detected with auscultation. The diagnostic workup may include a chest X-ray, rib films of a specific area, ECG, continuous pulse oximetry, and arterial blood gas analysis. Medical management. Medical management of the patient with a sternal fracture is directed toward controlling pain, avoiding excessive activity, and treating any associated injuries. Surgical fixation is rarely necessary unless fragments are grossly displaced and pose a potential for further injury. The goals of treatment of rib fracture are to control pain and to detect and treat the injury. Sedation is used to relieve pain and to allow deep breathing and coughing. Care must be taken to avoid oversedation and suppression of the respiratory drive. Alternative strategies to relieve pain include an intercostal nerve block and ice over the fracture site. A chest binder may decrease pain on movement. Usually the pain abates in 5 to 7 days and discomfort can be controlled with epidural anesthesia, patient controlled analgesia, or non-opioid analgesia. Most rib fractures heal in 3 to 6 weeks. The patient is monitored closely for signs and symptoms of associated injuries. Thank you. Please do like, share, comment, and subscribe. Thank you so much.